Good afternoon, everyone, and welcome. So, on behalf of the Campaign for Grade Level Reading, I'm really delighted to welcome you to today's conversation, where we'll be exploring the new National Academy's report, Early Relational Health, Building Foundations for Child, Family, and Community Well-Being. Today's discussion will explore a powerful bridge or through line of how the earliest relationships in a child's life shape brain development, resilience, and social emotional growth, and how those early connections lay the groundwork for kindergarten readiness, early literacy, and ultimately third grade reading achievement. The concept of early relational health reminds us that every child's learning journey begins not with a curriculum or a classroom, but with a caring relationship with the adults who see, respond to, and nurture them. To help us ground us in this concept and the new report, I'm excited to introduce to you Dr. David Willis, Professor of Pediatrics at Georgetown University's Thrive Center for Children, Families, and Communities, as well as the founder and director of Nurture Connection. Dr. Willis has been a leading voice in the movement to elevate early relational health as a critical public health and early learning priority. He will start us off by sharing the framing and key insights from the new report and how it advances opportunities to build strong, connected relationships in families and communities. After Dr. Willis's overview, he'll introduce our panel of report authors who will then share their own perspectives and speak to how their work connects early relational health with the foundations of early learning and literacy. Dr. Willis, pass it off to you.
Great. Thanks, Michelle. Good afternoon, everyone. If I can have the next slide, it would be great. And we're delighted here to bring our findings of our consensus study for the National Academy and to bring this to you who are focused on early learning, the foundations of early learning and third grade reading. If we can take to the next slide. I'm a developmentalist, long committed to building life course well-being for children and the families around them, knowing, having cut my eye teeth on the early learning agenda and recognizing that the foundations for early learning are the relational experiences and what we call the relational health foundations of life course health. These capacities of that not only serve in return, but the positive, nurturing moments of connection for the youngest of our citizens, our babies, our toddlers, create the foundation for building lifelong health and development. The next slide calls out that we call this space now early relational health, and it is foundational for health, mental health, educational readiness, and ultimately flourishing and well-being for the next generation. Next slide. And this has become ever more critical as the American Academy has embraced the knowledge and science of promoting early relational health, calling out for a paradigm shift in child health care that focuses not only on clinical activities, but rewriting research agendas and rewriting our collective advocacy. And what is so essential, and we love partnering with you with the campaign about third grade reading, kindergarten readiness, early literacy is a relational health activity that is foundational from birth. And those early experiences build that kind of generational capacity. The next slide, please. So we also have learned that this is not just within the health system, but actually the ecosystem that surrounds families. Not only the early learning centers of early care and education, home visitors and providers of all forms and family support, but this whole focus to help all families know that connectedness, positive, supporting, and nurturing simple interactions generates the foundations for life course health, not the least of which is early learning and lifelong educational abilities. Next slide. So it was within this context that we were able to come together with funding support from the CDC and from Trust for Learning to create to activate within the National Academy of Sciences a consensus study. A consensus study actually provides an independent, objective, and evidence-based study for addressing complex issues of our society. It brings together leading experts across the field to identify knowledge gaps, to create an authoritative report of findings, conclusions, and recommendations for actions. Next slide. And it's been amazing that we were able to pull together a committee that is cross-sector. A few of our members are joining us today, but I want to be clear that this consensus study brought knowledge and expertise from the fields of pediatrics, neurodevelopment, public health, social work, psychology, infant mental health, anthropology, cultural wisdom, and actually cross um, um, internationally from a colleague from Canada, but also guidance and direction and experience from a series of colleagues that are working in Australia. This was a consensus study that came together. I'm delighted today that some of our authors of the committee are joining us. Elizabeth Barak, who's a senior fellow at Georgetown Center for Children and Families, Dominique Charlotte-Sweeney, who's a clinical psychologist, assistant professor at Georgetown and the Thrive Center, and Justin Lavner, who's a professor and director of clinical training, Department of Psychology, University of Georgia. So let me lead us off with what the framework of the consensus study itself. Next slide, please. We had a statement of tasks that defined the work. That is to define what the link is between early relational health and long-term health and well-being. What are the impacts of early relational health on addressing the range of challenges and multiple levels of behavior, biology, epigenetics, neurodevelopment, and communities for addressing the needs of all children? Looking at what are the roots of early relational health to understand this work? What is the evidence about participating in family engagement, place-based initiatives in communities? What are the best practices that advance early relational health? And what can be the federal and state policies that support this work? Next slide. And we gathered from across the field and internationally themes for the community to help guide us. And the themes that came forth were both the science of human development and the importance of relationships are irrefutable. Supporting the well-being of caregivers is essential for creating the conditions for early relational health. Relational approaches are grounded in family, community, and cultural perspectives that offer community-based pathways for flourishing. We know that there are multiple influences of early relational health that are addressed across systems, policy, and the digital environment. We know, of course, that relational health requires advancing system-level supports. It is relationship-centered, and measurement and accountability become essential. And actually, this is a public good that has intergenerational returns. That's really essential for embracing this work. Next slide. Just calls forth that the multiple roots of early relational health include communities, families, and caregivers across cultures and backgrounds, all of whom have understood the importance of connection and relationships for human development that start early. Researchers, clinicians, and practitioners across the disciplines of development, education, health, and social sciences have all focused on the essential knowledge that early relationships are the seminal source for wellness and flourishing that's so applicable here to the early learning agenda. And the concept of early relational health has been introduced most recently here as an encompassing framework and orientation as anchored to families and communities that they care for their children and to society and policy choices that they make. Next slide. And the biological and developmental foundations are likewise well established. Relationships are biologically necessary for healthy development, well-being, and flourishing. Relational health evolves throughout the life course, but there's a plasticity and a critical element that begins early, and neural circuits of stress regulation and attachment form rapidly and early, and caregiving experiences early become biologically embedded. It's not the absence of adversity that alone is sufficient to promote early relational health, but the presence of adversity does not foreshadow and foreclose early relational health. It is those supportive relationships that are essential to contribute to resiliency and health. Next. So thereby, let me turn now to my colleague and dear friend, Justin Lavner. Can I turn to you now, please?
Great. Well, thanks so much. It's nice to be here with all of you today. And so wanted to start by reviewing some of the basic tenets of early relational health. And next slide. So when we're talking about early relational health, what we're talking about is this dynamic process of mutual, meaningful, and affirming moments of connection and the youngest relationships. And so this can be a variety of relationships. So commonly we think about this as parent-child relationships, but this could be other significant caregivers as well. So that could be childcare providers, that could be teachers, that could be extended family members, that could even be neighbors. And so here, really, again, thinking about these moments of connection. And what we know, and you'll see on the next few slides, is that it's foundational in shaping lifelong physical, behavioral, and mental health. Next slide. So when we're talking about these moments of connection, again, these can occur anywhere that children spend their time and socialize, so with their family, care, and community settings. You can see a long list here of other kinds of constructs that you may be more familiar with. So things like secure attachment, caregiver sensitivity, attunement, synchrony. Again, kind of all of these fall under the early relational health umbrella. It's a dynamic process, and there's these ongoing cycles of relating, rupture, and repair. And it's in the repair and kind of continuing kind of relating that early relational health is built. Also, again, want to note that this is experienced differently by each individual and manifests in person, family, and community specific ways. And so what we feel, express, and value emerges from the cultural and social worlds that we inhabit, and that these positive interactions may reflect communal as well as extended caregiving relationships. So again, want to emphasize that this is not just parent-child relationships that we're talking about. Next slide. So as David mentioned, one of the statements of task, one of the purposes was to look at linkages between early relational health and later health and well-being. And there's a large and robust evidence base that provides clear evidence for linkages between early relational health and children's short and long-term health and well-being. We see this across multiple domains, kind of grouped in terms of social emotional well-being and mental health, relational outcomes, as well as physical health. You can see a list of some of the different domains here, and the report gets into these in a lot more detail. But again, see this both in terms of fewer problems, as well as kind of more positive social behavior, as well as better physical health, even when we're looking at objective measures. And there's also some evidence from randomized controlled trials suggesting that these experiences are associated with the development of brain structure and connectivity throughout development. Next slide. And then in addition, early relational health serves as a buffer against adversity. And so here is a key source of resilience. So kind of protecting against the adverse impacts of stressors on children's stress biology, physical health, and psychosocial functioning. Next slide. And just want to emphasize in general that unfortunately kind of much more is known about adverse childhood experiences and toxic stress than is known about positive childhood experiences in early relational health. Fortunately, we've seen kind of a growth in this area in recent years. And again, some of the kind of relational elements that I've reviewed earlier, and that these positive childhood experiences are associated with the, improved health and well-being. So attuned and responsive caregivers, opportunities for play and reading aloud, participation in programs like Reach Out and Read and Play Read VIP are associated with healthy lifestyles, academic success, and economic stability decades later. Next slide. So early relational health, again, is about these moments of connection, but those moments don't kind of occur in a vacuum. So a big part of the report also was focused on influences on early relational health. Next slide. So again, as we talked about, it's a complex, dynamic, and cumulative process that includes a child's genetic predisposition and as well as environmental factors. So social, physical, community, and societal experiences. And we see many levels of influences. So these include individual, familial, and extrafamilial relationships, resource and community factors, and then finally public policy and macro level influences. And I'm going to briefly review the first two categories. So next slide. So when we're thinking about individual and relational influences on early relational health, so first, one of the things that we know is that sensitive and responsive caregiving matters and that predicts secure attachments. Again, this is true for a variety of caregivers. Characteristics of the caregivers themselves. So when we're thinking about parents, parental mental health, their own attachment history and emotion regulation skills are linked to the quality of caregiving and child attachment. Also note that dynamics within the family, so the couple relationship dynamics, co-parenting relationship are associated with early relational health. Again, non-parent caregivers or child care providers, grandparents contribute to children's emotional and social development and early relational health. And then finally, children's characteristics. So their emotionality and temperament are associated with early relational health. Next slide. Again, the broader environment matters too. So this kind of when we're thinking about resource and community influences, this includes economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and as well as the social and community context. So here, communities can serve as powerful, positive influences on parenting, child development, and early relational health. So here we're talking about the social networks, cultural traditions, faith-based organizations, and informal systems of support. Strong community ties that support caregiver well-being, promote positive parenting practices, and offer children consistent models of trust, belonging, and collective identity. Thinking about neighborhood characteristics. So are there safe public spaces? Are there opportunities for community engagement? Is there green space? Is there reliable transportation? What's the quality of local services? All of these create supportive environments that can foster children's learning, play, and relational security. And then conversely, we know that poor conditions can place chronic stress on families, which contribute to emotional distress in caregivers, including heightened levels of anxiety and depression. So again, here, although we're focusing on early relational health and these moments of connection, kind of again, these occur within a much broader ecosystem that can serve to kind of facilitate and strengthen early relational health or pose barriers. So with that, I'll turn it to my colleague.
Thank you.
Next.
Thank you, Justin. Delighted to be here with you. You are going to hear some of what has already been said. And we intentionally did this throughout the consensus study to really repeat and reframe some similar things. So here where I will be sharing how do we begin to think about supporting early relational health in early childhood systems. Next slide, please. Our systems in this space must be really relationship builders, not just service providers. So when we think about early relational health in the early childhood system, it's about really creating an ecosystem of connections that surrounds and supports every child's development. Next slide, please. As such, the community, the we emphasize rather a public health framework that is tiered, multifaceted, and cohesive. So in chapter 4 of the consensus study, what you will find are case examples of models and programs that work across the levels. So for example, at the individual and family level, we provide case examples such as healthy steps in the pediatric primary care. At the community level, we offer examples like public awareness, like small moments, big impact. And at the systems level, early childhood, Head Start, early Head Start as an example. Next slide, please. So we highlight 5 principles for embedding early relational health in systems that represent really moving from a top-down approach, one size fits all, which it never does, to a much more collaborative, relationship-centered practice. So first, the emphasis on authentic co-design means that families are not just consultants in this space, but are truly leaders that are supported and have voice in creating solutions that reflect their community wisdom. Second, embedding relational practices in every aspect of our work, from how we evaluate programs to how we train our staff. Third, one of the important pieces we believe that's often missing for practitioners is really creating a reflective space. So, the importance of practitioners having that space to come together to really engage in conversation and build relationships. Fourth, relational abundance mindset recognizes that every family and community has inherent wisdom and capacity. And finally, creating a sustainable family leadership means creating structures where families, as I said earlier, don't just participate, they lead. This builds community ownership. It ensures programs remain responsive to their evolving needs. Next slide, please. Part of doing so, as we think about family leadership, is really thinking how research and practice can become stronger when we build family voices and their experience, cultural perspectives directly into an understanding of early relational health. Not not just an afterthought, but really at the foundation. The key point here that's being shared is that this is a shared power, shifting from doing things for families to doing things with families as equal partners and leaders. Families and communities must be genuine partners in decision making alongside practitioners. This is not just about a checkbox or getting input, but really truly about co-creating solutions together. Next slide, please. And finally, just really a little moment of parent perspective. These parent voices really illustrate what family leadership actually looks like in practice. In the first quote, you'll see a parent highlights the connection between health insurance and early relational health, where she speaks of medical coverage in their family, how critical that is in the first year because it brings peace of mind. So, not having to deal with the stressor or the worry about finances, which allows this parent to be more available in creating opportunities to be with her babies. And in the second quote that you see before you, it really speaks directly to practitioners. The best way to promote early relational health is not through pamphlets or lectures or posters, but it really is by modeling it. How do we listen as practitioners and providers? How we talk to families, how we show up as trusted partners, how we repair when we do not get it right, because sometimes we don't. Um, Thank you. I will turn to my colleague, Elizabeth.
Thank you so much, Dominique. And I think hearing those parent perspectives at the end there really kind of grounds us in some of where we think policies have opportunities to go. So go ahead and go to the next slide. We know based on what you've heard in this ecosystem and the various ways that early relational help can come into play for young children, there's no one policy or system that's going to be the silver bullet for early relational health. Given all of these opportunities at the family, community, state, and even the national level. So we talked a little bit about how do we use early relational health as a lens to think through policies, both existing and new ones. So while we have some examples of policies I'll talk about on the next slide, we wanted to begin with a set of policy principles similar to those Monique talked about for systems to orient decision-making for policymakers. So we think these are the questions that can help guide and prioritize or even identify new policies that have potential to create those conditions at each of these levels that are conducive to promoting early relational health. So it's like many of the things we talked about. Does this policy help promote ERH for every child and family? We talk a lot about programs that serve low-income families because we want to make sure basic needs are met. But as you've heard, flourishing can happen regardless of where a child is, regardless of their income, and how can we create those moments of connection in every space. But family economic security is really important. Are these policies helping to promote that and minimize that kind of stress on families? The big one here, I think we've talked through, how do we scale and sustain these community-driven solutions that have demonstrated success, whether that's through a very well-researched model or have a really good track record that could use additional research beyond that community. Co-designed, of course, with families, advancing what we call a relational workforce, which can really be any, whether it's a child care professional or staff within a pediatric practice. How can each of these folks, community health workers, doulas, they all have an opportunity to help advance relationships around those children, and how can we help both train and grow that workforce? And last but not least, we really have always kind of lifted up this importance of access to mental health services in general when they're in need. We already know that that's a gap, and particularly for young children where it might not be recognized, and so we wanted to call that out. So next slide, please. Ooh. And the next, there it is. Okay, so there's lots more detail on some of the policies we identified, of course, in the chapter, but The first one is Medicaid. Medicaid came up as a potential area to do more to advance early relational health. Of course, we know, based on what parents have said, merely having health coverage is a form of economic security, but it's also a major coverage source for children. Nearly half of all children in recent years have been covered by Medicaid, and the vast majority of low-income children under the age of 6 are covered by Medicaid or CHIP. So it offers the greatest potential connection opportunity to children before they reach kindergarten, reaching children and their families. And we know because those well child visits in the early weeks, months, and years following a birth are more frequent, it's also an opportunity to reach those parents and reach the mom and the baby together, the parent and the child together, the family and the child. And so we also talked about opportunities to do more to promote that. We know Medicaid's benefit is very comprehensive for young children or for children all across the board, but we know its potential has not been tapped, particularly in ensuring kids get the preventive care that they need. And so while it's not only Medicaid's role, Medicaid as a major payer for young children and their families has an opportunity to help rethink the entire way the health system responds to young children and their families and serve that parent and child together. So there's a lot of examples in the ways that states have tried to do more to ensure care without a diagnosis in Medicaid, particularly for young children, to making sure that services are available for parents and children together and serve the relationships surrounding children. And certainly states are increasingly use Medicaid to pay for doulas or community health workers or others that can help to build that needed trust between families and the health system and other supports in their community. Of course, we talked a lot about this notion of helping meet families' basic needs and the role of nutrition programs, particularly WIC and SNAP, also early care and education, paid parental leave, which is something that's very popular in states right now, and how all of these things can come together to create the support surrounding families, particularly in those early years. And I like to think about the early care and education system, for example. It's not only a critical support to give peace of mind to parents as they need to work, but it also offers through the staff in early care and education or like a Head Start Center, the opportunity to work and work with those families and support those families and their range of needs. And I'll just say here, for the first two bullets especially, we know we're in a particular time right now where families are potentially going to lose some of these supports. We certainly addressed some of the uncertainty and the additional challenges that states and communities are going to face because of this, but we also wanted to think long term. So we acknowledge the real challenges ahead, but also think it's even more important to talk about the importance of these early relational health. Cross-sector collaboration, of course, came up a lot because of the different systems that influence early relational health. And again, there are lots of ways to look at this, and policy can play a really direct role in making sure it encourages or connects systems and the resources in communities. We talked again about how many places are using Medicaid or other sources to pay for healthy steps, pediatric primary care enhancements to help serve as a hub for families and their children, or programs like Family Connects or home visiting that can help do that as well. And of course, finally, all comes back to what if this relational workforce, which we thought about in a very expansive way, but how do we not only grow and train that workforce to reorient towards early relational health or keep doing what they're doing, but also make sure that they are well taken care of because we need them to be healthy and strong to be able to help leverage that early relational health in families and communities as well. And my final note will just be that we had a note in the chapter about the importance of implementation, because we can have the best policy in the world on paper, but if states and national leaders aren't regularly monitoring and providing oversight for the implementation of those with community input and engagement, as we heard from many of our guest speakers, then we have a lot more work to do. So thank you so much. I'll turn it back to David.
That's great, Elizabeth. Thank you. If I could have the next slide, is finishing up to the next slide. The committee, of course, started thinking and making recommendations about future research that are really essential. We have some research that's really that is compelling, but we need certainly far more. not only interdisciplinary approaches that integrate methods and findings across disciplines, but we also need participatory research that partners intentionally with families and communities to what matters to them in the designing of longitudinal and participatory activities. And also importantly, we've got to be thinking about population health measurements and infrastructure, common metrics and indicators and messaging that play out in local neighborhoods and communities where families live, because that's where the seeds and the foundations of relational health and building future flourishing and well-being and educational learning takes place. Next slide. So just a few final thoughts from the report and from our panelists, which is early relational health is foundational to lifelong health and well-being. It's everyone's business. Early relational health is a national imperative. Not only it outcome from this good imperative yields workforce readiness, economic and educational readiness, and lifelong health, but also builds resiliency and social cohesion and stronger community connections and meaning. Lastly, advancing early relational health requires efforts at all levels: families, communities, systems, and policies. It requires a mindset shift from risk to a strength-based relational approach. It requires support for family-driven policies, and it requires, of course, greater investments in system building, enabling strong relational supports around families. So I give great thanks to my panelists for joining me today and for this opportunity to be with you at the campaign. And so let me turn it now back to you, Michelle, for the next panelist.
Thank you so much, Dr. Willis, and thank you to all of our authors for grounding us in the science and systems behind early relational health. Being in the field of early childhood for the last couple of decades, I really feel like I've been in a room full of rock stars. So what a tremendous opportunity for us listeners to hear directly from all of you authors. So what the report makes it clear, and what I love what David just said, is that it's everybody's business. It makes clear that nurturing relationships between caregivers and children and across the systems that support them shape not only social and emotional health, but also early language, literacy, and cognitive development. So we'll now turn to our second panel. It's a group of distinguished leaders and practitioners who are working every day to strengthen those early connections in families and communities. They'll help us reflect on what these findings mean in practice across different systems and different sectors, from healthcare to human services to early learning, family engagement, and community systems, and how the recommendations in this report can help inform, inspire, and accelerate their own work. So I'm joined by an incredible group of leaders, and I asked them to join me on the Zoom stage. Their full bios will be linked in the chat. So today we have Lee Beers, Professor of Pediatrics at the George Washington University School of Medicine and Health Sciences, Maggie Casp, Senior Research Consultant at National Association Family School and Community Engagement, Ron Ferguson, the Founding Executive Director of The Basics, Adrian Pedroza, National Executive Director of Abriendo Puertas, Opening Doors, Jade Woodard, President and CEO of Family Connects International. So the Early Relational Health Report really calls for this cross-sector collaboration. Thrilled to have you all here who represent many different sectors. And today, what we're going to do as a group is really explore these ideas through 3 interconnected themes that reflect both the report and the realities of practice today. So these themes are connection in this moment. Why does this matter now more than ever? Trust in the surround sound of relationships. So what does that mean? Families experience multiple layered relationships that shape their well-being. And then targeted universalism and belonging, ensuring that every family experiences relational health. Before we jump into those themes, I do want to ground our audience on who you are and what you do. So if you could all just take maybe about 90 seconds to just talk about, introduce yourself, and at a high level, share how your work connects to the ideas in the report, and how early relational health is a foundation for early learning, literacy, and healthy child development. So I'll just start and I'll just call you out. Maggie, can you just start us off?
Oh, sure. Thanks, Michelle. And hi, everyone. I'm Maggie Casp. I'm a senior research consultant at the National Association for Family, School, and Community Engagement, or NAFSCE, as we like to call ourselves. And we're a membership organization that works to connect research, policy, and practice to promote innovative strategies in family and community engagement that promote children's learning and development in school and beyond. And Reading through the report and hearing the presenters today, I think what I find so exciting is that it really begins to highlight all of those interconnected relationships that we know shape a child's life. And I don't want to sound too much like Uri Bronfenbrenner here, but at its core, as Justin laid out, family engagement is really about strengthening that parent-child relationship, but it's also about those relationships between families and educators, and then at the next level, the networks among families themselves. So, this constellation of relationships is really at the heart of what family and community engagement is. So having a report like this to point to is just, really great.
Thanks, Maggie. Lee?
Well, wonderful. Thank you. And again, thank you all for having me here today. My name is Lee Beers. I'm a pediatrician. I practice primary care pediatrics at Children's National in Washington, D.C., and spend actually most of my time now leading a team called the Community Mental Health Core that's focused on really increasing access to mental health care in our local DC region. We have a particular focus on mental health prevention, promotion, and integrated healthcare, really leveraging and cultivating multidisciplinary teams. As you might imagine, to do that work, we have a heavy focus on early childhood, early relational health, and community engagement. I actually have the great pleasure of working with Dr. Charlotte Swilley, one of the authors of the report. One example of the work that we do is Healthy Steps. I see there's many Healthy Steps specialists on the call, or some at least on the call right now, which is a program that integrates developmental specialists into primary care and multidisciplinary teams. So, again, this concept of early relational health is really infused through all of what we do. So I'm really excited to have the chance to talk more about this today. I'll just add actually that I will be leaving Children's National shortly to begin a role as Chief Medical Officer of the American Academy of Pediatrics in January. And I'm really just so delighted to bring these concepts already embedded in much of the work of the Academy's Healthy Mental Development portfolio, and excited to continue that work.
Thank you, Lee, and congratulations on your new role. I will pass it over to Ron.
Hi, I'm Ron Ferguson. I'm an economist by training. I recently retired after 41 years teaching at Harvard Kennedy School, and for about 15 of those years, I was the faculty director of the Achievement Gap Initiative, which led to the work that most directly connects to what we're talking about today. Although about 35 years ago, I, with a lot of other people, discovered that skill gaps are probably the main remaining reason that we have wage gaps between racial groups. So I became really focused on skill gaps and dealing with differences between people from different backgrounds. And if we are interested in skill gaps that predict wage differences, where do the skill gaps come from? They come from children's lived experiences. And so if we focus on children's lived experiences, we think about, again, back to the Bronfenbrenner framework and all the different settings that matter. And for me, early relational health is one of those big anchoring ideas that helps us to in simple ways, talk about what we're trying to do, because all of us are really trying to affect everything. We're trying to affect families' lives and how welfare for overall. And so I think for the work that we do, we started an initiative called The Basics that works through lots of different organizations. I'll say more about that later. But it's really all about early relational health, working through the social ecologies where children live. And I'll stop with that.
Thanks, Ron.
Okay.
Adrian.
Hi, Michelle. Hi, everyone. Great to be here. What a great report. Just hearing about the tenets, the foundation of early relational health, I can't help but to think of the work of APOD, of what those opening doors are over the last 20 years, and how we really invest and focus on the relationships between parents, caregivers, their young ones starting at birth, but also their peer relationships and how they build social capital. Our approach is really working with trusted community partners. We have over 3,000 facilitators across 42 states who are embedded in trusted family serving organizations who implement our approach that uses popular education pedagogy really believes that parents and caregivers are the experts of their local environments and need to reflect on their own experiences as young people and as they were raised by their parents and how they're now parenting. And so we really look at to parents and caregivers as leaders of their households and communities, and look forward to this continued conversation. Thank you.
Thank you so much. And Jade.
Good afternoon, everyone. My name is Jade Woodard. I am the president and CEO of Family Connects International. Family Connects is an evidence-based model for in-home nurse support for all families in the early postpartum period. So that really looks like a nurse visit about 3 weeks postpartum for all. We are implementing in about 65 communities in 20 states across the country. I saw many of our partner organizations in the participant list, so it's great to see you all here. Ultimately, I think, it's a common cliche that having a baby doesn't come with an instruction manual. And I think we've all heard that. And the reality is that is true, but it doesn't have to be. Having a nurse that can come to your home and hold your hand and look in your eyes and tell you it's okay, you've got this, provide a little education, a little support, and some resource connections where you need them can really be life-changing for families and can really set that foundation and that stage for early relational health and long-term success. So I'm really excited to be here and have this conversation today.
Thanks so much, Jade. So now with that, we will jump into our first theme, which is connection in this moment. And so we've been hearing throughout today that early relational health is really this dynamic process of mutual, meaningful, and affirming connections. And so coming out of years of disruption, disconnection, and inequity, many families and the systems and practitioners created in service to families are still rebuilding that sense of connection, alignment, and shared purpose. Lee, can you just start us off by saying how you're seeing some of these connections and shared relationships show up in your work, and if you can share examples of how their communities are intentionally designing for connection and shared leadership?
Yeah, absolutely. And thank you so much for that, because I really, it is one of the things about this concept of early relational health that is so important is this interconnectivity both between parents and caregivers and their children, but also amongst each other. I'll share perhaps a couple of examples of where we're seeing that show up in our work that is really powerful. One of the initiatives that we help support is a model called Parent Cafes, which many of you are probably familiar with. But it is a space where sort of a parent-led and guided space using sort of structured conversation tools that parents can come together and really focus on supporting each other and building up their protective factors. So our team serves as now provides technical assistance for groups across the city to implement parent cafes in their settings. And they're just such really vibrant places. And we've been able to really work with parent leadership through these cafes to even sort of co-develop some of our own, what they're called decks. And full credit to my team and Dr. Nia Bodrick and Randall Baylor who led this work. But it really is powerful. And even through some of this work, some of the parents have come together actually and created their own leadership group where they've been really focusing on policy and advocacy issues, which again has been a very powerful thing. We work with another organization called Spaces in Action, who are a community organizer. They do community organizing here in Washington, D.C. And they really focus heavily on storytelling and leveraging storytelling and really supporting all of their parents and caregivers and community members who are a part of their network to share their stories to help create connection and cultivate change. Oh, Michelle, I
You're
think
on mute.
you're muted.
I was trying to save you all from the dog barking. Anyway, thank you, Lee. Adrienne, do you want to chime in with some of the ways that you're seeing communities across the country are intentionally designing for connection and shared leadership?
Absolutely. So, we know when we ask parents and caregivers, what matters to them, it is relationships, it is connections. We do a national Latino family report annually. And when we ask parents and caregivers what they look for in support in raising their children, they talk about wanting to connect with other parents and caregivers. They talk about feeling isolated at times and needing to be able to really share their experiences, their challenges that they might not be able to share with maybe their partner or the individual co-parenting with them. And so what we see across the country and communities are parents excited, parents being excited to come together, both in person and now virtually, because of the pandemic kind of forced us into also to work on our approach virtually, or even in a hybrid way. But what we see parents wanting to do are really to reflect on their own experiences, on their own challenges, and to be able to share that with other parents, so they are sort of realizing and seeing that they're not alone in these challenges, and they're able to work through some of these challenges, not just that they might be facing in their household, but also some of the environmental challenges or economic challenges that they're facing. What we hear from our parents and caregivers is that they want multicultural, linguistically relevant also approaches. Over about 60% are saying that they want that embedded into their early childhood services, according to our National Latino Family Report. And so we work to ensure that we are really understanding the cultural and linguistic experiences of parents and caregivers, and how that shapes also the way they parent and the way they seek out their community to support their child's well-being.
Thank you so much. Jade, you also work directly, your organization works directly with families. Anything you want to share about the isolation or reflection, or how they have come together to share some of their ideas?
Absolutely. I think it's really key to kind of what you just said, Adrian, around how the time of the pandemic and the isolation that families experienced. The reality is there is no substitute for human connection. The ability to, connect with another person in a vulnerable time, in a challenging time, to have someone that you can connect to. And that could be a professional, like within the case of Family Connects, it's a nurse in the home, but that could also be, a peer, a friend, a neighbor. And so the way that we really seek to normalize connection, to normalize support seeking, I think that's really part of developing early relational health is learning those skills, but also, practicing building those muscles, being able to reach out, to offer support, to ask for support, to make a phone call for a resource, and to have someone there that can guide you through that. I just think, right now, as resources are changing, or as we're concerned about what might or might not be available for families through traditional systems into the future, how are we kind of leaning in and learning how to connect with each other and really kind of pursue what that support can feel like into the long term together.
Anyone else? Ron, you want to add anything there?
Yeah, I mean, what our work does with the basics is to try to create a shared project that spans the community, that brings people together around a shared set of language and goals. And we try to integrate our work into the work of others. And so we kind of add on top. Our first principle is maximize love, manage stress, which connects very directly to relational health. And so we work through dozens of community partners in each city, and we've got 60 some active communities now, where each one of those partners is integrating into its own work encouragement for families to pay attention to their own stress levels, to pay attention to the way that they express love and affection to their children, and to share ideas across different organizations. And so having a bunch of different organizations in the same city talk about how do we integrate into our work encouragement for families to express affection, to talk to their kids, to talk about books and numbers and play and so on. That sharing itself helps to build in the relationships between the different frontline organizations, even, that helps to create this ecology of support. We talk about socio-ecological saturation, saturating the parents' social ecology with support for building these principles into their everyday lives. one other thing I'll just add here in this, talk about this particular time with the government shutdown. What we're seeing in a lot of communities is people starting to put together food banks. And so you say never waste a crisis. We have a lot of new social capacity being used, old social capacity being awakened and reused in this moment. And all of us can be a part of that too.
Thanks, Ron. And Maggie.
Yeah, the only other thing I'd add to this conversation is, at NAFSCI, we often think about how designing for a relational way of being really requires that we build professional capacity to do it. So whether that's through educator preparation programs or through coaching or professional learning more broadly. So in other words, we have to be really intentional about designing for connection and shared leadership by making dedicated spaces for our home visitors or our doulas or our early education staff to really be able to practice these relational skills. And I think of a report that Frameworks Institute put out a number of years ago, where they really called attention to this misconception that, family engagement is about caring, that educators who partner with families do it because they care, or this like more insidious message that parents who don't like quote unquote become engaged don't do it because they don't care. And we know that that's not true. What research really shows is that, what it's really all about is building confidence, skills, and having opportunities to engage. So one of the things that we do at NAFSCI is we've put out the family engagement core competencies, which are freely available on our website, but they really describe sort of the knowledge, the skills, and the mindsets that help family-facing professionals build strong relationships with families. And they align perfectly and have relationships baked into them. I won't get into the nitty-gritty, but they're really about, and many people have already said this, but how do family-facing professionals reflect on their own biases and shift their own mindsets about families? How do they connect through authentic relationships, collaborate and co-design, and really share power and lead alongside families? So I appreciate that question a lot, because I think building those systems really needs to take that workforce development into account.
Well, Maggie, let's stay with you since you were talking about the core competencies, because I think that's a good framework or a way to think about as the second theme, where we think about trust and the surround sound of relationships. So we know families don't experience one relationship at a time. They experience a network of relationships from pediatricians, teachers, home visitors, and that sometimes the surround sound can either reinforce safety and belonging or cause more confusion and stress, which is why these core competencies are so important. But just in thinking about this theme, how do you see the surround sound of relationships shaping trust and connection with families across systems? And how might we align these networks? And thinking, given our webinar today's focus, thinking about how these networks align towards kindergarten readiness as well.
Yeah, when I knew you were going to ask this question, so when I gave it a little bit of thought ahead of time, and I really wanted to call out some of the work at the Center for Family Math that NAFSCI is engaged in, which is sort of built on this idea that much like literacy and learning to read, math learning is not confined to classrooms. It's deeply relational, cultural, and connected to families' everyday lives. So we almost think about family math as having charging stations across different community spaces, which is not a mysterious concept to everyone here, but this idea that how do we embed family math into homes and parks and libraries and museums and pediatric offices. So I think one of our partners, Dr. Frances Harper at the University of Knoxville, I think, is a mathematics educator, and I think really is emblematic of this idea, because she partners with Muse Knoxville, which is this children's museum, and El Centro Hispánico, which is a local community organization, to co-design family math and literacy nights with parent leaders and aspiring teachers. And they've created a series of modules that new teachers can use, and they've created modules that families can use to really explore math. But I bring up this example, I think, because what the evidence from her work really shows is that, you know, also doing this work builds relationships. Aspiring teachers felt more connected to families. Families felt more connected to the museum and other community providers. And they even felt more connected to one another. So, you know, thinking about the surround sound, these charging stations, but really thinking about all those important places to connect.
Thanks, Maggie. Ron, you look like you're ready.
I was thinking when I think of trust, I usually am anchored on what I call the 4 trust questions. And people are asking these questions about the people, the individuals that they're interacting with directly. Can I trust your motives? Can I trust your competence? Can I trust your dependability? Can I trust you to respect me? And for any individual, any one of us who's trying to attract partners and collaborators, we need to be trustworthy. And so we can each look in the mirror and say, am I trustworthy with regard to my motives, with regard to my competence, my dependability, my respectfulness of others? But then we're also trying to build ecologies of trust, whole communities where parents can step out into the neighborhood and feel like they can trust folks. And so how can we build communities where families think, oh, all the people around here, they got the right motives. They really do want to help me. They really do know what they're talking about. They really are going to keep their promises. They really are going to treat me right. And so the challenge is, what are the activities, what are the projects through which people come to learn that they can trust the environment? And each one of us has different programmatic activities. And if we can help to create whole ecologies where people can be trustworthy, then families can start to feel that way. And in those ecologies, we can work together as organizations to help one another become more trustworthy. So each of us as an organization can say, what can I do to help your organization be more effective, which will help to create this spirit, this culture in our community that leads people to feel relational trust in general. Because in general, most of us don't touch families directly. We really touch families through other people. And so this big project is a big adult development project. And how do we cultivate that adult development project in ways that have people trust sufficiently to invest their time and energy in the kinds of successes that we all aspire to?
I love that, Ron. I love that working with other organizations and how they can help create that sense of trust with families, but also amongst each other, amongst organizations too. And so I don't know if anyone, Lee or Jade or Adrienne, want to talk about that at all?
Yeah, I can jump in here quickly. I think, you know, one of the components of Family Connects is the connection, the handoff or the referral to other resources or supports in the community that are, you know, identified and desired by the family to be connected with based on whatever that conversation is with the nurse in their home. And as you were talking, Ron, I think what was really coming up for me was this idea of, you know, how the nurse is there with the family, connecting with them, hearing, you know, what they're going through. And part of our model is that they're connected to and aware of what else is in that community and able to say, you know, oh my gosh, I know that there's, you know, a parenting group that meets down the street at the elementary school after school. You know, that might be a good fit for you. Or, you know, whatever it is, that they're just able to really identify in that moment where there might be connections, and then they're kind of building already off the trust that they've developed in that moment, and then starting to transfer that into those other community organizations to really build that ecology of trust. I loved that phrasing.
Yeah, I mean, I think I'd love to just, you know, really, I guess plus one to everything that has been said, because I do think, you know, one of my colleagues, you know, he says that, you know, we work in silos as professionals, but families do not live in silos. And so they engage with all of us in so many different ways. And I think, you know, I feel really grateful in my career as a pediatrician to have been able to really work with many different multidisciplinary professionals and community members and organizations and parents and families. And, you know, I think one of the things that always strikes me is that we really all share a North Star, but we speak different, languages about how we accomplish that work. And sometimes that leads to miscommunication, right? And sometimes that leads to misunderstanding. And I think we are all working, I'll, name this for all of us. I think we are all working in fields that are really pretty under-resourced. And so our teams are very stretched and strapped. And the work of collaboration is that it's work. It requires time and resources and the ability to take a step back from that day-to-day, work with families and submitting grant applications and all those other things that fill our time to build those connections and relationships amongst each other so that we can create systems that families can then flow through seamlessly. And so I do think that's really important. And that's a place where, I think as individuals and as individual organizations, we can lean into that in the work that we do. But I also think those are places where there's great opportunities for systems change because our systems are set up in a way to put us into silos. And so thinking about how can we begin to think differently and how can we begin to think about how to redesign some of our more global systems. It's some of the work that we've tried to do here in DC, some pieces successfully, some pieces less successfully, as you might imagine. But I do think thinking about how we break down some of those structural barriers to all of us working together in that service of really lifting up and supporting children and families and supporting that early relational health. And again, I think maybe it was Dr. Charlos Willie who said, just like really recognizing the abundance and power within every family.
I would just say using the phrase early relational health is one of those ways.
Yeah, and if I could jump in, absolutely agree that, as Lee said, that I think we have a collective North Star that we're all working on to build trust, to build community. At the same time, there's a movement to create distrust that's happening, that we see and to create division. And so I think we absolutely have to continue our work, but also understand that right now, many parents and caregivers, we serve families of mixed immigration status, and a third of them back in February in our 1,400 survey of families said that a third of them are saying they're not going to send their kid to early childhood services, that they're afraid to go to work, that they're afraid to be out in public in these spaces where we're trying to build relationship and community. Families are saying that they still, primarily, at higher levels, trust other family members, trust, their immediate community. And so, we got to work hard on that trust and to really build relationship between families in these systems to ensure that when families interface with systems or institutions, that they do have welcoming environments, that they do understand that they still have basic rights in our systems and institutions, their constitutional rights that are many times now being violated out on the streets. And so this division, this movement to create division is real. And I believe that this community right here that we're speaking to is the counter to this division that's being created.
I really appreciate you calling that out. And that actually is a great segue to our next theme. But before we go into the next theme, I do just want to call out something that Lee said, well, that collaboration takes work and it takes funding. And I just want to acknowledge, I know that there are funders out there in the world right now that are recognizing that and they are funding collaboration. So I just want to give kudos to those funders that are funding collaboration and bringing organizations together to help support this. So with that, I'm going to move us into the next theme, which is around targeted universalism and belonging. So key message of the report is that early relational health is for everyone. It's a universal human need. But as the report emphasizes, and as we all know, as in this room today, achieving that requires some targeted strategies that center equity and family leadership. So I'll start with you, Ron. How can we apply targeted universalism in early relational health, supporting every child's sense of belonging and potential, and creating the conditions for thriving and learning from birth through third grade?
All right. I think universalism is the idea that what we're talking about is universally relevant. A lot of us are in this business because we want to help those families who are most marginalized, who are most at risk for not being well off. But we don't want to stigmatize either. We don't want to say that we're just doing this stuff for those people. And so I know in our work, we talk about 5 principles of early childhood development: maximize love, manage stress, talk, sing, and point, count, group, and compare, explore through movement and play, and read and discuss stories. There's nobody for whom those are not relevant. Okay. But we're doing this because, at least for me, I saw how big the racial achievement gap was by the time kids were 2 years old. That's why I, as an economist, got focused on early childhood. And so I want to focus on people likely to end up on the bottom side of that gap. And so we've have framed work that is targeted to support those people. But when we go out and do public awareness, we don't say it's only for those people, it's for everybody. And we get everybody using our stuff. So each of us needs to think about, how do we do our messaging in ways that communicates universalism, but the targeting of our work in ways that devotes our resources towards supporting the people who most need those resources. Okay, and there's a balance to strike in that.
Anyone else want to add to how we find that balance?
I mean, I think maybe I'd add, right, so much of this is really hyper local. It's so deeply dependent on the family and the neighborhood and the community context in which you're working, and I think that is a something for us to really think about when we're thinking about solutions and how to. And I agree. I think so many of these these concepts are all really universally applicable, and some families, may need a little more guidance or support or connection in one place than another. And that's that's going to be very, very individual. But I also then sometimes think about, or I often think about, so how do we, in the roles that we have, where we have the great privilege of having access to this information and some of these resources and curriculum and training materials, how do we take that to that hyper local level? How do we take that to the crossing guards and to the coaches, and to the members of the community, parents and families too, right? How do we take this information to them? Because I think they're ultimately the ones who are going to really develop. Um, uh, um, they're the ones who are really going to most deeply understand the needs of the children and families in their community.
I guess I want to the just if we're going to be pushing a national movement for relational health, that's kind of a high level idea. And within that, we do have to pose Lee's question: how do we take it to the places where it's going to make the biggest difference? But what does that high level thing look like? What does the national discourse on relational health look like? And what's the relationship of that to the work on the ground with the families that Lee is talking about?
Yeah, I couldn't agree more that the work needs to be local. And the way APOD approaches it are facilitated, discussions, amongst groups of parents. So there's this peer interaction, and we start with really, presenting, throughout the courses, the science, the evidence, the research, because many times we have the misunderstanding or the belief that maybe, parents and caregivers don't want the hard, the ground truths and the hard evidence. And that's absolutely incorrect. That's some of their biggest aha moments that they share is, wow, I did not realize that the synaptic connections are forming before a baby can even talk. And now I know to interact with my child and to have those high quality interactions, at birth. And then we move to understanding parents and caregivers' self-interest. What are their personal experiences? What experiences are they having as they interact with their children at home? And that self-interest then moves to a shared interest, because in sharing these stories and these experiences, parents and caregivers realize that they have a lot more in common in those shared experiences of their maybe own upbringings, but also in their, some of their the strengths, assets, and also challenges that they're seeing at home. So we really move from self-interest to a shared collective interest, and then hopefully to action and advocacy, right, to leadership at their local and community levels.
At the founding research of Family Connects International found that 94% of families upon the birth of a baby had a need for some sort of support, education, care, resource connection. And I think that really resonates for me in this conversation. All families needed something, but they didn't all need the same something. They didn't all need the same level of something. And so really for me, it's thinking about, how do we support families in having access to what they need, when, where, how they need it in a way that's tailored and meaningful for their culture, for their choice, for their context, for their community, and really thinking about that kind of being the basis for then families being able to form those connections with their children and with their communities when those kind of base needs are able to be met.
Jade, when you say how do we support families, I'm thinking who's we, right? Often when
All
we
of
think of the
us.
we, we're thinking of us as service providers. But if the we is the bigger society,
Yeah.
what does the messaging to the broader society look like that gets everybody to be looking out for opportunities to support families? The people that they run into on the street by accident, having a sense of we-ness that leads them to
Yeah.
want to find ways to enrich this particular family's life.
Well, that's a great thought to leave us with, Ron, to think about who the we is and the societal we-ness of it all. But I want to save time for some Q&A. So I'd like to invite all of the panelists on screen now. Thank you to you all for the second panel for this lively and engaged discussion. I'm really grateful for you. So if the rest of the panelists can join, we are going to put it out to the audience. What are some questions and questions you have for us? And we'll bring the full panel together. So let's see, some of you, do we have any questions that we want to ask? If not, I'll kick us off with one. The campaign for grade level reading focuses on helping children read proficiently by the end of third grade. What are some of the key relational ingredients that really help build those early literacy foundations? So I know we mentioned a lot of these already, but just kind of culminating it in this
Let me throw one on the pile. I used to
okay.
do a lot of survey work in school systems. One of the invisible problems is teasing, peer teasing as of kindergarten. And so, how do we create peer dynamics in schools that allow kids to ask not to avoid help, for example? I'll stop with that.
Other panelists want to add?
I really appreciate Ron's question. I think all too often, as I walk through the halls of schools and early Head Start and early Head Start, and especially Head Start before babies are transitioning to the pre-K and K space, some of that is coming up. And I think working on social emotional, on connection and compassion, babies can learn compassion and
I've got a
empathy.
four-year,
And
I have a 4-year-old granddaughter who's dealing with peer dynamics at preschool.
yeah, yeah. I'm not surprised by that at all, given the climate of where we live. But really, babies can learn these small little people, young, they could learn that compassion and empathy. It is about creating that space of, we talk about early on serve and return. Serve and return is not only happening in the space of babies, it's also happening in this age group that you speak of your granddaughter. And so creating opportunities to really pause and engage in emotional language, giving babies emotional language of how did it feel when this happened in that space, and beginning to really have empathy for one another. I think that's part of that work.
The question, as I heard it called out, and Ron, I like the word we-ness, the we-ness of learning, meaning that way back at that shared reading, those moments of connection, of shared learning, that storytelling, that pointing together, that sharing, such that learning and education is a we experience, not a me experience. And that kind of process starts young to help young children discover that the learning from others at every level is meaningful, and the dialogues of that, where you take relational health into relational learning, relational spaces of connectedness really matter.
somebody used the phrase moments. I forget who it was. I think it might have been Justin that talked about the moments where relationships are experienced. And we can think about those moments as the unit of analysis, and how do we instigate more of the moments where people have positive relational experiences, and realizing that learning is a relational process, and that we can plan and plant those moments in all these environments where we function.
Any other last thoughts on that question? No. Okay. So one of the things that I like to do in these kinds of webinars is and the conversation with a sense of hope or inspiration. And so when you look ahead, what's one change or shift, either big or small, that gives you hope for how early relational health can continue to shape the future of early learning? And that could be at the policy level, at the hyper local level, just anything that you might want to share.
I'll pitch in. Our multi-city network meets monthly around the year, and we had 2 presentations at our most recent meeting. And people were talking about going around the community to engage new partner organizations, and they were saying nobody is saying no. All the organizations they're inviting to be involved, oh sure, we'll do that. And pitching up, and I think we're in a moment where people are looking for hope. They're looking for ways to be connecting with one another. They're looking for ways to contribute. And so I think it's hopeful that people are stepping up and not stepping back at this moment. And watching the news, all the soup kitchens that are putting together in anticipation of food support being cut off pretty soon is hopeful.
Ron, that gives me hope, and it reminds me that next week we have 23 communities across the country where practitioners, families, and community leaders believe that they can advance a relational health frame in their communities, and they want to be together, which surprised us. We didn't expect that degree of interest. Then my second space of hope is from what we learned from our family network collaborative of Nurture Connection, and the families that we are able to have the privilege of learning from the neighborhoods in what are called living room conversations of families that have 0 to 3-year-olds. They love their children deeply, and they learn and they value our focus on relationships, because that's the center of the way that they think. Every family has a baby that they love, they care for, and that networks of connection is something that matters to them greatly. That brings me hope.
Yeah.
I'll jump in and just say, I think the fact that we had this consensus study done, right, by the National Academies of Science and Medicine, right? Like that's kind of really kind of taking a big kind of stake in, and that this is funded by the Centers for Disease Control and Prevention, right? Like this is again like a really big endorsement at a really high level of the importance of this. And so again, there's kind of a lot to still be done, but I think also the work kind of, I think the report kind of lays out like how much has been done. And I think does kind of show just investment at lots of different levels as well. So that gives me a lot of hope too.
Yeah, what really gives me hope, a lot of what has already been said, is really the return in so many ways to community, and the focus on, we know the shrinking that's happening across medical fields, psychologists, psychiatrists, pediatricians, and the like. So creating opportunities for paraprofessionals, for families with lived experience to really receive knowledge and skills to take back into their communities. So starting a program, as we have done at Georgetown, for community health workers to really learn competencies of not only community health, but also the overlay of infant and early childhood and family mental health. And so going back into their communities and taking that knowledge, and so many states now creating opportunities for families who have acquired this knowledge and skills to be there as cultural brokers in a medical space, in a community space, or early childhood space. That gives me hope.
Beautiful. And I, just want to jump in because, just what you said, what gives me hope is last weekend I was invited to a convening of parents and caregivers who had been through the APOD program, facilitated experience over 10 weeks, and we're now getting certified and wanted to give back and facilitate, with their communities and their local communities throughout New Mexico. And what's exciting is just to see that energy of having received and then wanting to give back the knowledge and the experience that they've been given.
I'll just build off that and say I happen to be in New Mexico, and we also on the panel had the great fortune to hear from the Secretary of Department of Early Childhood, and it is state leadership. There's an incredible amount of state leadership out there in many places, and certainly at the community national levels too. But in New Mexico is a great example. Through every system we've talked about today, from Medicaid to childcare and others, they're going to have universal childcare in a mere few days in New Mexico because of an unrelenting commitment to young families from every level. And I do think there is a real possibility when young children and their families and communities are prioritized, we can really think differently about the world. Not to say there aren't challenges ahead, but there is leadership out there to do it.
And it was a movement of community, parents, and families that pushed through over 15 years to make that happen. So
absolutely. And I think you can tell me if not, Jan, but they do a pretty good job talking about that engagement and have a governance structure that tries to do that too.
Well, and I'll express my sadness that the wonderful Secretary for Early Childhood in New Mexico came from DC. So we miss her deeply, but we're so proud of what and just so impressed by what she has done there. I'll share. Actually, I've been to a number of professional meetings over the past few weeks, and most recently last week had the wonderful opportunity to hear Brian Stevenson speak at the Academy of Child Psychiatrists meeting, and I even wrote down. I pulled my notebook over. I wrote down this quote. He said, "Hopelessness is the enemy of justice," and so what gives me hope is that everyone continues to come together in the service of justice. And so I really appreciate these gatherings like this and these larger gatherings that we go to, and I can always feel the sense of purpose amongst those who are gathered, and that gives me a lot of hope.
And I'll just chime in quickly that, I think what gives me hope about this report and just about this conversation today is really the emphasis on co-creation. I know Dr. Barbara Rogoff was part of this, fabulous report writing. And, I can imagine a report written only 20, 30 years ago that wouldn't have taken such a broad view of what we mean by early relational health across communities and cultures, and that this is part of our way we do business now. It also gives me a lot of hope.
Well, Jade, did you want to?
I can be very quick. Just, I think there is continued recognition of this fourth trimester, the early postpartum period, and just how critical that is. We see that in states. We also see that in some of the advocacy around paid family leave, but also investment in maternal health. And so I think that's giving me a lot of hope that we've just really begun, I think, to really acknowledge that moment as really critical for families.
Can I start on one thought? I mean, as we move ahead, we think about Bronfenbrenner, this big macro ecological idea we're talking about of relational health. As we go forward, though, we need to get really specific about which relationships are we talking about and how do we help support, because all the way between the mother and the child to between the legislators, and what are the dynamics that we need to understand better to manipulate more effectively in order to have that system work the way that it does, because there's a danger of hovering at a high level, talking about early relational health, but not getting specific enough to make as much difference as we ultimately want to.
I love that, Ron. Well, thank you, everybody. Thank you to all of the panelists for such a rich discussion today. What gives me hope is all of you and the great work that you are doing, and all of the folks that joined us today, because we have a collective we, and I think we had 700 people register. So that's at least 700 people that are ready to start to build this national movement for early relational health. And I know that there are thousands more that would join us. So thank you to everybody for today's conversation. And let's continue working working together to really build these systems and communities that make those relationships possible for every child and family.